Perfect. So I'm Maria Sor Andres. I work at the Royal Brompton Hospital in London, and I'm going to present to you our study on cardiovascular events in CML patients treated with nilotinib. Sorry. I have no declarations of interest, and well, we all know that the therapeutic landscape of chronic myeloid leukemia has been transformed by tyrosine kinase inhibitors. And nilotinib, which is a second-generation TKI, showed even higher rates of major molecular response than imatinib, its predecessor, the first-generation TKI. However, in the NS trial, it was also associated with higher cardiovascular toxicity. So we designed a study with the aim to describe the cardiovascular events associated with nilotinib in a real-world population, and also to assess the predictive value of the HFA-ICOS risk score, which is currently recommended by the ESC 2022 guidelines, Cardio-Oncology guidelines. We included consecutive patients with CML treated with nilotinib between 2006 and 2021 in a specialized center in London, and calculated the HFA-ICOS risk score in retrospective for all patients. We define our primary endpoint as the incidence of all cardiovascular events, and the secondary endpoint as the combined secondary endpoint as the incidence of ischemic events, and compare the risk and the incidence of events stratified by baseline risk category while the patient was on nilotinib. As results, we included 229 patients, and the incidence of all cardiovascular events in this population was 21%, during a median time of treatment of 34.4 months, and the incidence of the secondary endpoint was 13%. The bar graph shows the distribution of the cardiovascular events that we encountered in this population, and the table shows you the demographic characteristics of the patients. When comparing the patients who develop a cardiovascular events and those who didn't develop a cardiovascular events, patients with an event were older at the time of commencement of nilotinib, had a higher ECOG performance status, and had a higher prevalence of CKD, chronic kidney disease. When putting all of these factors into a multi-variable logistic regression model, we identified male sex and age, so older age at nilotinib commencement, as independent risk factors for cardiovascular events in this population. In terms of comparing the incidence and the risk of events based on the baseline risk category, we found that the lower the risk, the lower the incidence of events, and vice versa. The higher the risk, the higher the incidence of events. And this was for both endpoints, cardiovascular events and ischemic events. For example, for cardiovascular events in the low risk category, there was an incidence of 11.2% compared to an incidence of 32.4% in the high and very high risk category. And after doing the chi-square test for trend, this was statistically significant. And the hazard ratio in the higher group was 3.55 compared to the lower risk categories. This also replicated for ischemic events, with a incidence of events of 5.2% in the low risk compared to more than 21% in the high and very high risk, and the hazard ratio almost 4 compared to the lower risk counterparts. Now, we also explored the association between the dose of nilotinib and the events and the development of events. And we found that in patients without a cardiovascular event, the median total dose of nilotinib at the end of follow-up or when finishing treatment was significantly lower than the median total dose of nilotinib at the time of the events in patients who did have an event. Kaplan-Meier curves showed that there was also a significant difference depending on the risk category and the time to event. So the higher the risk categories, the shorter time to an event. And in terms of the overall performance of the score, the AUC, so the area under the ROC curve, was calculated as 0.65 for cardiovascular events and a little bit higher for ischemic events, 0.68. Interestingly, other performance index showed that For cardiovascular events, the score showed a sensitivity of 73% and a negative predictive value of 89%. And for ischemic events, it showed a sensitivity of 79% and an impressively high negative predictive value of 95%. So our conclusions today, are that the HFA-ICOS risk stratification tool is an efficient discriminator between low and high and very high risk categories, and that it has good sensitivity, high negative predictive value. It's really good at identifying those patients that are low risk and can go directly to having their treatment, but some efforts may be directed towards improving the specificity and refining the overall predictive performance. And we need also prospective multicenter studies for further validation of the score. But in the meantime, this study gives us enough evidence to support the recommendations of the guidelines. Thank you very much. And if you like to read the whole paper, you can find it in Cardio-Oncology Journal. It has been published 2 weeks ago.
Thank you very much. Very